This PowerPoint will deal with hemorrhagic lesions of the feet. Now, these are some case studies of patients we have seen recently in our practice. While not common, you will see them from time to time, so it's nice to know about how to treat them, where they come from, to be better equipped to advise the patient on treatment. This patient was referred for leg pain and lesions on the lower extremities. She is a 72-year-old female, smokes 1 pack of cigarettes per day. Now, note the mottled appearance on her dorsum of her foot. This is evidence of hemorrhagic purpura in the past. Now, this patient has new lesions on the digits that are painful. I ordered a CT scan and referred her to a vascular surgeon who does arterial work. The CT scan revealed ulcerative plaque in the abdominal aorta. So obviously these are the result of embolization. Now, this was a 72-year-old, very obese male, referred for swelling and macular non-blanching lesions of the lower extremity. At first, they appeared to be stasis lesions, however, they are not. There was no GSV insufficiency noted on examination. Now you can see the pulsatile flow in the popliteal vein here. It's very indicative of just sometimes either of congestive heart failure, benign cable compression. So I'm going to show you in a minute the clinical presentation. Okay. There are many capillaries with red cells present. Numerous capillaries, such as seen here, is not found in normal states. Note the circular configuration of the capillary grouping. Now, this may represent high venous pressure in the postcapillary venules. When we talked about stasis changes, true stasis changes actually have hemosiderin deposition. In this case, we have many capillaries with red cell thrombosis. This is a 58-year-old female with bilateral telangiectasia in both lower extremities, mostly on the feet. She has no GSV or SSV reflux, mildly obese. These telangiectasias appeared about 2 years ago and have gotten worse. Now, we see probably 15 to 20 patients a year with this kind of pattern that is labeled as generalized essential telangiectasia. No real known etiology for this. They start usually, the telangiectasia, on the feet, and they can spread upwards to the knees, the thighs. They can involve the arms and the back as well. There's a characteristic finding with these telangiectasias, which we'll show you a little bit later on the histology analysis. Now, this is a histology of generalized essential telangiectasias. Note the dilated vessels are present without true muscle wall hypertrophy. Now, this one histological feature differentiates generalized essential telangiectasia from cutaneous collagenous vasculopathy, or CCV. In CCV, you'll have a thickened wall with hyaline, not muscle. But as you can see in this patient, the muscle wall is not that thick. You can see the endothelial cells present. There are numerous small venules present throughout the reticular dermis, right underneath the squamous epithelium. So this is a very characteristic pattern for GET. Now, sometimes, even histologically, it's very difficult to differentiate GET from CCV. In CCV, there has to be specialized stains that actually stain for hyaline. However, histologically, on a eosinophilic stain, you can make out that usually there's thickened wall with CCV as compared to GET. Now, note that the histological specimen on the right is a little bit different from the one we just showed you on the left. You can see that the medial wall is more thickened, not with smooth muscle, but with a homogeneous type of appearance that's due to the hyaline. Now, as I said before, sometimes it's really difficult to differentiate these two conditions. Really doesn't make much difference because the treatment's about the same, which is light-based therapy, which we'll talk about later. Now with GET, numerous treatments have been tried, including tetracycline, Silvarix, with some limited response. However, in our experience, using a laser or IPL will give you the best results, and we'll talk about that in a little bit. Why these lesions occur, no one really knows. They're usually not associated with systemic disease, although GET may be associated with other hemorrhagic telangiectasias, such as in the stomach or the eye. But most of the time, they appear by themselves. Now, this patient had treatment in some areas with the V-beam laser. You can see some clearing of the lesion. On the right is a histological specimen which shows thrombus present. This was taken about 2 days post-treatment. There's thrombi present in the vessel lumen. This is the only way really to treat these. You can try other wavelengths of laser, but 595 seems to be the best in treating this condition. Now this lady presented with bilateral telangiectasia of the feet that started about 2 years ago. She's 38 years old. No history of familial disease, no history of venous disease in the family. Her saphenous vein, short saphenous are normal. Deep venous exam is normal. These telangiectatic lesions started on the feet, spread to the knees, and now the arms. This is a classic pattern of GET. As mentioned before, no one knows why these really occur. I think that GET and CCV are very closely related. The treatment remains the same. 595 laser, 595 nanometer laser, or an IPL with a 595 block. That seems to give the best result. Other lasers have also been used, such as a YAG. We do not see good results with the 940. As mentioned before, medical treatment has included tetracyclines, has included Silvarix. For what reason, I do not know why she was given that, but she did have clearance with that. However, other studies have not found any benefit with medical therapy at all. So this is a disease that's really treated for purely cosmesis. And as mentioned before, if you do not have these lasers, try to find someone who does have a laser and hopefully has some experience in treating these lesions. It does take time to clear all this up.